Welcome back to our second video, and in this video I'm going to cover respiratory volumes, capacities, and flow rates. So in this section, we are going to talk about the different lung volumes and capacities, define dead space, and indicate some different types of information that can be gained from pulmonary function tests. So first topic we will cover is lung volumes and capacities. So in terms of volumes, it's first important to understand that this graph represents the graph recording of a spirometry test. So basically, you put a mouthpiece in a person's mouth and you have them breathe normally, and the graph kind of records the breathing cycles. So first and foremost is tidal volume. This is going to be the first volume that we're looking at. And the tidal volume is the amount of air that's moving into and out of the lungs with each breath cycle. And this is occurring during normal, quiet breathing. So as you guys are sitting here listening to this video, you are probably breathing a normal, quiet ventilation. And so as you're sitting here listening, you are most likely inhaling and exhaling about 500 milliliters of air. All right, so your inhale and your exhale, your inhale and your exhale. Now the next value that I'll talk about is the inspiratory reserve volume. And to describe this one, we have to understand that first we take our inhale for our tidal volume, and then anything else that can be inhaled is inspiratory reserve. So if all of a sudden from this point I told you to take the biggest, deepest breath in that you could take, this biggest, deepest breath in that you can take minus your tidal volume inhalation, anything that's left over that you inhaled is your inspiratory reserve. And normally this value is between 2,100 and 3,200 milliliters. So it's the amount of air that can be forcibly inspired beyond our tidal volume. Similarly to inspiratory reserve, we also have expiratory reserve volume. And so that's going to be this segment here. Expiratory reserve is any extra air that can be expelled from the lungs after you have a normal exhalation. So remember, tidal volume is normal. So if all of a sudden at the end of your exhalation, I was like, okay, push out any extra air that you can, you would see a tracing following my pointer here, which matches this tracing here. So this is expiratory reserve volume. And normally this is only about 1,000 to 1,200 milliliters. Finally is residual volume. And the residual volume is the amount of air that is remaining in the lungs even after you have breathed out as much possible air that you forcibly can. And so that's kind of all this extra down here. So basically the residual volume is giving us an indication that even though we have pushed out all of the air that we think we can, there's actually still some remaining in the lungs. And this air that's remaining in the lungs, the residual volume, helps to keep the alveoli open and also helps to keep the lungs from collapsing. And so at any given point in time, you have about 1,200 milliliters of air remaining in your lungs so that the lungs can remain inflated. So moving on to capacities. Capacities are simply those volumes that we just talked about, sort of added together in different ways. So first and foremost is inspiratory capacity. So that's your take the biggest possible, deepest breath in that you can take, all right? And that whole big, huge, deep breath in is your inspiratory capacity. So then this is going to be the sum of our tidal volume and our inspiratory reserve volume. Next is the functional residual capacity, or the FRC, and this is the amount of air that is remaining in the lungs after a normal tidal volume expiration. So after you exhale, there is going to be a pretty significant volume of air remaining in your lungs. And by exhale, I mean passively. I'm not telling you to push any extra out that you can. So the amount of air that's remaining after a normal exhalation, a quiet exhalation, is going to be equal to your functional residual capacity. So this is going to be your expiratory reserve volume plus your residual volume. Your vital capacity then is the total amount of air that you're actually exchanging. So remember I said the residual volume is just the extra air that gets left in the lungs no matter what. There's always about 1,200 milliliters of air sitting in the lungs to keep them inflated. Everything else minus residual volume is vital capacity. All right, so that's your biggest, deepest breath in and your biggest exhalation, pushing out any possible air that you possibly can. All right, so all of that volume is vital capacity. Again, the sum of the tidal volume, the inspiratory reserve, and the expiratory reserve. And then finally, the total lung capacity, it's the sum of all 4 lung volumes that we discussed. So the inspiratory reserve plus the tidal plus expiratory reserve plus residual. All of those things added together gives you the total lung capacity. Okay. So the next learning objective here is dead space. And dead space is just referring to the part of the lungs that is not participating in gas exchange. So in terms of the types of dead space, we have 2 major types, but really only one plays a significant role in determining dead space. And also it's important to understand that in a normal, healthy person, um, and really in most people in general, dead space tends to be a value that does not change. Um, so first and foremost is the anatomical dead space. And the anatomical dead space is just referring to the volume of the conducting zone conduits. So this is just air that is going to remain in the passageways. So remain in the lungs and remain in the trachea and probably our primary bronchi as well. And usually this is about 150 milliliters that never actually reaches the alveoli and therefore does not contribute in gas exchange. Now, different from the anatomical dead space then is the alveolar dead space. So we account for this alveolar dead space sort of separately. And so this would be space that would be occupied by non-functional alveoli. And the reasons that you might have some non-functional alveoli would be perhaps lung collapse or obstruction or some other sort of lung pathology that has functionally destroyed the alveoli. So then, of course, our total dead space is the sum of our anatomical and our alveolar dead space. And so this graph is just kind of showing, so here's a normal tidal volume, which we said is about 500 milliliters, right? So your inhalation and your exhalation. And you can see of this very normal tidal volume, we really only are able to send about 350 milliliters, give or take, to participate in gas exchange. So of the 500 milliliters, maybe only about 350 milliliters does participate in gas exchange. Everything remaining does not. It never, and I use never always very cautiously, but the 150 milliliters remaining never contributes to gas exchange in the lung. Okay, so that's something to keep in mind, especially if we're talking about disease that has affected the alveoli, and therefore maybe your alveolar dead space increases. You can see that that would leave far less air remaining in order to participate in gas exchange, okay? All right, so that's just a little bit about dead space. So now we're going to move on and we're going to talk about pulmonary function tests and talk about some of the information that we can gain by performing pulmonary function tests. So what are these pulmonary function tests? And a lot of times they're just called PFTs. Basically what these are, they're tests that are used clinically to evaluate losses in respiratory function using what's called a spirometer. And these tests are generally used to distinguish between obstructive and restrictive pulmonary disorders. So from these tests, we can gain information by measuring the rate at which gas is moving into and out of the lungs, so how quick the gas is moving into and out of the lungs, and then also the volume of air that is flowing or the volume of air in the lungs. So in general, obstructive disorders, so I'm going to come over here to this side. Obstructive disorders are ones that cause a reduction in the flow of air. So this is a rate issue. And the main reason for this is because we're going to have an increased resistance to airway flow. And so some examples of this might be bronchitis, emphysema, COPD, or asthma. These are all what we call obstructive disorders. And so if we kind of take a little zoom in on this little picture over here, if we zoom into this little section, we can see maybe some inflammation in the bronchi and maybe some mucus buildup. Ultimately, what this is going to do is going to, one, dilate our alveoli, and two, it's going to trap the air that's in the alveoli so that the air can't escape because it's sort of plugged by mucus or by the inflammation. All right, so effectively what this does is it sort of hyperinflates the lungs, okay? On the contrary, so this, again, remember, this is a rate or an airflow problem. It's a reduction in airflow. Restrictive disorders have been classified as being those that reduce lung volume. So as we can kind of compare the two, obstructive versus restrictive, obstructive lung volumes, actually obstructive disease makes the lungs bigger. Restrictive diseases tend to make the lungs smaller. So restrictive disorders are diseases or environmental agents that will reduce the total lung capacity. So examples of this would be tuberculosis or pulmonary fibrosis, or rheumatoid arthritis can also lead to restrictive lung disorder and lung disease. And as you can see from this little picture, the damage to the alveoli has caused scarring, and if there's less alveoli, there's less available. So kind of this is a situation in which our alveolar dead space would increase, and so therefore the total amount of air that you can actually exchange would be decreased. So on this next slide, I have a really good sort of comparison between obstructive versus restrictive diseases and how you can kind of put them in their own boxes and make an analogy. So start over here with obstructive disease. Some signs and symptoms would be shortness of breath and coughing. Because we are dealing with a respiratory issue. But in terms of obstructive disease, remember this is an increase in resistance to air. So specifically, these patients are going to have difficulty exhaling, and their FEV1 to FVC ratio is going to be impaired. Specifically, they're going to be unable to exhale quickly, and we'll talk about what this is here. And ultimately, in addition to having that impaired or decreased ratio, our obstructive patients are going to have increased residual volumes and increased functional residual volumes. Remember, because this is the air trapping situation. So the sort of analogy to kind of think about obstructive diseases like road lane closures that are causing traffic buildup. So that can kind of hopefully draw a picture in your mind a little bit about why this would be a problem, right? So we're reducing rate. We're reducing the cars from moving quickly down the highway by placing the sort of construction zones or destruction zones, I guess, in the case of obstructive disease. So again, some examples. This is a very incomplete list, but asthma, bronchiectasis, bronchitis, COPD, cystic fibrosis, those sorts of diseases. Kind of comparing obstructive to restrictive disease, although restrictive disease, still patients you will see have shortness of breath and coughing. Their main problem is that they have a difficult time expanding their lungs. So the analogy to make here, it's like a hot air balloon that's trying to expand inside of a house. And so it's kind of like the lungs are trying to expand in their house in the thorax, but there's just not enough room. Specifically for the alveoli to inflate, they just don't have enough room. And so these patients tend to actually have problems inhaling rather than exhaling. And so although our FEV1 and FVC are equally impaired, the ratio between the two is actually normal. And unlike obstructive disease, where our residual volume and functional residual volumes are increased, in restrictive diseases, we have the inspiratory residual volume and inspiratory capacity being decreased. So things that might cause restrictive diseases are things like fibrotic changes, scoliosis, muscular dystrophy, ALS, and ankylosing spondylitis. And again, this is a very incomplete list, but I just wanted you guys to see a really good comparison between the two, obstructive and restrictive diseases. So back to talking about pulmonary function tests and how they can give us some really useful information. First and foremost, I mentioned this already about spirometry, but it's the most useful way to evaluate respiratory diseases, because using spirometry, we can distinguish between whether a disease needs to be classified as being either obstructive or restrictive. So some of the different things that we're going to look at using spirometry are going to be forced vital capacity and forced expiratory volume. And these are going to be values that do indicate the rate that air is moving into and out of the lungs. So let's first talk about forced vital capacity, or FVC. This measures the amount of gas that is expelled or exhaled when a subject takes a deep breath and then forcefully exhales maximally as quickly as they can. So you have your patient take a deep breath in, and then you're like, blow out every single ounce of air that you possibly can as quickly as you can. Forced expiratory volume is another thing that we can sort of gain information about by using spirometry. And forced expiratory volume is going to determine the amount of air that the patient has exhaled during a specific time frame of the forced vital capacity test. And usually forced expiratory volume is looking at a 1 second time period, because most people, a healthy lung function, most people are going to be able to blow out about 80% of the volume that they inhaled within 1 second. Okay, about 70 to 80%. So usually we measure the FEV in 1 second. So it's usually, you'll see it in the literature, or maybe you'll learn it in other classes as FEV1, the forced expiratory volume in 1 second. Now, the reason why these things are useful is because obstructive and restrictive disorders, they differ in their rates of FEV and their amount of FVC. So, excuse me. So, looking, I put an example here for an obstructive disease. So the orange line you see is a normal spirogram, and this section that's going up, so this would be amount over time, right? So this normal healthy lung person blew out like 3.2 liters in 1 second, okay? About 3.2 liters in 1 second. If you compare that to a person with an obstructive disease, then what you'll notice is that as you follow their tracing in the same amount of seconds, so in the same time frame, in 1 second, a COPD patient is only able to blow out 2 liters compared to the 3.2 liters that a normal healthy person could. So again, this 1 second mark is giving us our FEV1, or how much the patient blew out in 1 second. And then once the patient has blown out as much as they possibly can, that is going to give us the forced vital capacity. So the maximum amount of air that can be blown out after a deep breath in has been taken. So you would measure FVC by looking at the flat part of the curve. And basically you would just draw this over to the volume side. So for our healthy person, the FVC is a little bit more than 4 liters. For our COPD patient, their FVC is going to be a little bit less than 4 liters. Okay, but what is really significant on this graph, and what is something to pay attention to in COPD patients, is this FEV1. Okay, so in obstructive diseases like COPD, these patients are going to have increased total lung capacity, and increased functional residual capacity, and an increased residual volume, simply due to hyperinflation of the lungs. Whereas in restrictive diseases, you will see low vital capacities, low total lung capacities, lower functional residual capacities, and lower residual volumes due to the fact that they are unable to effectively expand the lung. So the other thing that you can look at and gain information from in terms of testing is by looking at the minute ventilation or alveolar ventilation rate. So minute ventilation describes the total amount of gas that's flowing into or out of the respiratory tract in 1 minute. And so for a healthy person, this is about six liters every minute. And it's also important to keep in mind that with exercise, this value can actually increase up to 200 liters a minute. So a majorly significant increase. But the minute ventilation is really only a rough estimate of how efficient the respiratory system is being. So the better indicator of effective ventilation is this thing that we call AVR, or alveolar ventilation rate. And this measures the flow of gases into and out of the alveoli during a particular time frame. And why this is a little bit of a better indicator is because it takes into account the amount of dead space in the patient, takes into account the tidal volume that the patient is performing, and also how quickly the patient is breathing. And so it can be calculated by using the following equation. So alveolar ventilation rate is equal to the frequency, so how many breaths per minute the patient is taking, multiplied by the ratio of the tidal volume to the dead space. And what's kind of important to keep in mind too about this equation is that, remember I said in an individual, this dead space is normally a really constant value. So AVR ultimately tends to be influenced by the tidal volume that your patient is breathing and the frequency that the patient is breathing. Now, significant increases in AVR are brought about by mostly by increasing this tidal volume rather than increasing the frequency, because even if you increase frequency by maybe rapid shallow breathing, ultimately that can actually um, decrease the AVR. So I have this graph down here. It's showing the alveolar, the effects of breathing rate and the depth of breathing on alveolar ventilation in 3 hypothetical patients. So in the first patient, we have a very normal rate and a normal depth. So they have a dead space volume of 150 milliliters, and they have that very normal 500 milliliter tidal volume and a very normal respiration rate of 20 breaths per minute. And so their minute ventilation, then by taking these values, you come up with 10,000 milliliters per minute, or in terms of the AVR, that's 7,000 milliliters per minute, which in terms of that's effectiveness. So this is effectively um, breathing in terms of ventilation, about 70%, 70% effective ventilation. So now what we're going to do is we're going to look at our second hypothetical patient. And in the second patient, they are breathing more slowly and deeper. And so they have the same dead space volume, because remember I said typically this is normally a pretty constant amount. But remember, we have deeper breathing, which means they're going to have a higher tidal volume, but they're breathing really slowly. So their respiratory rate has decreased. Their minute ventilation is going to be the same, but their alveolar ventilation, notice, is not the same at all. These, in our slow, deep breathing patient, their AVR is 8,500 milliliters per minute. This is an effective ventilation of 85%. So it's kind of interesting, because when you think about these deep, slow breathing, you think about, I think, calming down or meditation, and why that would be effective. And you can see this is why that's effective, is because it ultimately is helping you to actually oxygenate and exchange gases more efficiently than a normal breathing situation, and certainly more efficiently than the last situation that we'll talk about, in that is this rapid shallow breathing, such as an example of rapid shallow breathing would be like hyperventilating. So again, dead space volumes remains constant, but this is a really rapid breathing and a really shallow breathing. So since it's shallow, you're not going to have as high of a tidal volume compared to normal. Specifically in this case, compared to normal, our tidal volume is cut in half, but our respiratory rate is actually doubled. And so when we do the math for calculating minute ventilation, we're still at 10,000 milliliters a minute. However, when we look at our actual AVR, the alveolar ventilation rate, we're seeing that it's only 4,000 milliliters per minute, which is an effective ventilation of only 40%. So when you're hyperventilating, you're not actually effectively moving and exchanging gas, which ultimately can lead to poor oxygenation, passing out, and so on. Okay, so that's just something that's kind of interesting to take into account whenever we are looking at these different tests that can be used to determine how well the lungs are functioning. So that concludes this video. And in the final video that I make, I will be covering oxygen and carbon dioxide transport in the body and also gas exchange. Okay, so I will see you then.